Hello, everyone. My name is Jaydira Del Rivero. I am a medical oncologist at the National Cancer Institute, and it's my pleasure to be with you today and discuss when do we make treatment decisions in patients with neuroendocrine tumors.
Hi, my name is Chandrasekharan. I'm a genetics oncologist. I'm currently at MD Anderson Cancer Center and then Neuroendocrine Tumor Group. Thank you for inviting me to this panel.
And I'm Callisia Clarke. I'm a surgical oncologist at the Medical College of Wisconsin. Again, really excited to be here today talking about my favorite topic.
Hi, everyone. I'm Erik, Mittra, a nuclear medicine physician at Oregon Health and Science University, and great to be a part of this group. Thank you.
Thank you, everyone. One of the aspects in the management of patients with neuroendocrine tumors is to understand the decisions about the various therapies available for patients living with neuroendocrine tumors. And I would like to start a question to Dr. Chandrikha. And the question that I would like to ask you is, when do you make the treatment decisions of a patient who is newly diagnosed with neuroendocrine tumor?
Yeah, I think I'm glad that our panel is very balanced with the different specialties here. I would like to say, if as much as possible, I would like to have the patient meet with the different specialties involved in this cancer's management through the course of their journey. Oftentimes, by default, patients end up first seeing the medical oncologist. In some institutions or some places, they may end up seeing the surgical oncologist. Dr. Mittra, who's a nuclear medicine, they probably are not maybe the first point of contact for a patient with this cancer. But with different clinical treatments coming up with PRRT upfront, certainly nuclear medicine or interventional radiology, the other specialties can also be part of the discussions in the very beginning. So I think the first thing for a patient when we see them is how symptomatic or how is this cancer affecting them? I think that's always the first question we all ask ourselves, because a lot of us know that some patients have no symptoms, just incidentally diagnosed, they had a scan for something else. I think the path we take definitely starts from symptoms and how the patient is affected by the cancer. I'm not talking about the mental agony of being diagnosed with the cancer, but just the actual physical aspects. And then a lot of us will make our decisions based on if we know the grade or the biology of the cancer. I think that's a good starting point for me always. And then figuring out from there, depending on the scales, the treatment options they may have, whether they need to meet a surgeon first, they need to meet, or are they very symptomatic? We need to think about maybe some patients PRRT first or embolization first. So symptoms, grade, and a presentation, the patient's preferences again.
And now that you mentioned PRT, maybe I can ask a question to Dr. Mittra about if you could maybe describe a little more in detail what makes someone an ideal candidate for PRT. Maybe you can discuss difference of PRT now that we have alpha and beta for our patients to know and what PRT stands for. That would be great.
Sure. Yeah. So PRRT stands for peptide receptor radionuclide therapy. Currently, there's only one FDA-approved version of it, which uses this isotope called lutetium-177, which is a beta emitter. It's been around since 2018, and we have a lot of evidence in terms of how to use it. Typically, it's used as a second line or later treatment after some of the other treatments that my colleagues here will have done. But some of the new evidence that came from this study called METTER-2 shows that you might actually be able to use it more as a first-line treatment, as Chandrikha just mentioned. So that's something that we evaluate together in a multidisciplinary tumor board. Everything that we do often is based on the imaging. So once you have a PET scan done showing high uptake or low uptake, depending on what it shows, then we'll kind of discuss everything in the tumor board and then make a decision whether we should do the treatment earlier or perhaps do a different treatment up front. And then as far as the alpha that was mentioned, this is kind of the next generation PRRT that everyone is very excited about. There's a lot of ongoing research with that. Several different clinical trials are in sort of phase 2 and phase 3 right now. So we don't have any FDA approvals on those, as we probably get in the coming years. But once we do, most likely we'll be able to have both the standard lutetium PRRT as well as some of these alpha therapies available in the future.
Great. Thank you so much, Dr. Mittra. And that will be a following question as well for Dr. Clarke, newly diagnosed patient with neuroendocrine tumors that they have different presentations. Some of these patients may have more what we call localized disease. Some of those patients, they have more of advanced metastatic disease. And the question will be, when would you recommend surgery? When would you call our surgeons? And make the treatment recommendations on a patient with metastatic neuroendocrine tumor?
I typically see two presentations for patients with neuroendocrine tumors that are newly diagnosed. One common scenario, unfortunately, is an intraoperative consult for somebody who has now a new diagnosis of a neuroendocrine tumor, but is presenting with a problem, an obstruction, a perforation, any kind of complication from the tumor. And obviously, in those settings, we often are offering a surgical procedure to palliate what the immediate problem that the tumor is causing. And that may not even be a curative or even truly cytoreductive surgery. We're just trying to manage a particular problem. That's becoming, I think, unfortunately, in my practice, a much more common scenario for which I'm meeting patients for the first time. But I think a more typical setting is in a somewhat elective fashion. Typically, patients have been having mild or maybe nonspecific symptoms for sometimes years that were sort of unrecognized and undiagnosed, and now they've come to the new diagnosis of neuroendocrine tumor, and they're seeing me or my partner in a clinical setting. So we're fortunate enough, and I think as are probably all of the experts on today, to be at institutions where we have neuroendocrine clinical centers of excellence, and we're often seeing patients either on the same day or in conjunction with at least one of our partners. So I typically will see patients with my medical oncologist on the same day at the time of their initial diagnosis, and so they get to meet both of us. I'll talk with them in general about what the surgical options are for their particular disease. And then I'll mention to them that the good news is we actually have had an explosion of innovation in the space of neuroendocrine tumors, especially over the last 5 to 10 years. And so now we can actually have educated discussions about how to layer in each therapy to try to maximize survival for our patients. And so I'll often say, while technically your tumor is surgically resectable, we are going to have a multidisciplinary conversation where all of our experts can weigh in on what tools they have to offer. And we'll figure out what's the best sequence of therapy so that we can try to ensure that you are alive as long as possible and symptom free as much as possible from your tumor disease. So we almost never make the final recommendation for treatments at the initial visits. I almost always tell patients that we're going to discuss you in a multidisciplinary tumor board. We meet weekly. And so we usually set up a phone call or virtual visit right after that multidisciplinary tumor discussion to finalize what the treatment plan is going to be.
Thank you so much for that answer. And a follow-up question, one aspect, and that also has been discussed throughout the different talks today, is to also understand not only the difference in neuroendocrine tumors when a tumor is more indolent versus maybe more aggressive behavior or more rapidly growing tumors, but also in that sense, when we discuss about K67, does that help you as well to make treatment decisions and treatment recommendations?
Yeah, I think it has to be put in the context of a few things. So I would say often the first piece of information we have is the biopsy, which again, for patients who are newly diagnosed, just to clarify some of these terms, under the biopsy, we classify these neuroendocrine tumors basically into categories, grade 1, 2, and 3. The grade 1 is kind of the slowest, most laziest kind of tumors, then grade 2 is a little bit faster, and grade 3 is faster. So in that order, and then we also have some the same selecting very aggressively as a poorly differentiated neuroendocrine, what we call a carcinoma, very aggressive. So the biopsy is often our first picture into this cancer, the disease, and that's what we base what we expect it to be. Sometimes though we may have prior scans or images, so we have to also look into that. I always try to ask patients, have you ever had any scans for anything in the past that covered that organ? And that can give us a clue as well. Say we got a scan from 3-4 years ago and we found a lymph node that's in the abdomen now was also there, but that gives us an idea about the slow pace or biology based on if we have prior imaging. And then of course the clinical symptoms, right? So some patients clearly will tell us, gosh, I've had diarrhea going on for 3 years, this severe. And probably then they may have had a metastatic or a spread cancer with small bowel neuroendocrine already. So it's not just the K67, and we have to realize that, we can't put our, like all the decisions just based on one thing, but certainly K67 or the grade of the tumor is one of the first factors we have that helps us plan a move. Because clearly, if I see a patient who's got a biopsy that suggests what we call a grade 3 neuroendocrine tumor, or kind of the faster growing type, then I'm going to be a little bit on the guard and tell the patients, I'm going to watch you closer. I'm going to be more, maybe there's, we expect this may grow a little faster, but we don't know. So we have to watch you closer. Probably if I see a patient with a grade 1, no symptoms, I'm really going to tell them, or I also have a scan from 4 years ago that I see something that was there before, then it's very reassuring already. And we have, that's reaching the patient to us and say, listen, we can watch it. We may still see you 3 months, but probably we're going to be fine even if we see you in 6 months. And so K67 is one component, not the only component. Well, like 20% is a cutoff. It doesn't mean 21 is really bad and 19 is really good, right? So it's just it's just kind of an index. It's a continuum, as we say, meaning like we are estimating how many cells are dividing, and it's not a perfect number by any means. It's just helpful in some ways because it's validated that it has been shown to tell us more about the behavior of the tumors while we use it.
And discussing a little bit about the behavior of the tumors, that will be a question for Dr. Mittra. Which patients or when would you consider doing a gallium-68 dotted scan versus an FDG PET scan? Because as Dr. Chandrikha said, some of these tumors may be very well differentiated, which we know they're more avid on dotted scans. Some of them are more grade 3, that some of them may not express, all of those tumors may express somatostatin receptor, for which it seems that maybe FDG PET scan may be a better option sometimes, but maybe a question for that. When would you decide what would be the best diagnostic therapy? Would you do both, or what would be your recommendations in this situation?
There's different imaging modalities that we can use to kind of help better understand and capture this behavior throughout the whole body. And one of the nice things about these types of PET scans is that, we're looking at the entire body at once, as opposed to a biopsy, which is just looking at, one small area within the body, or even just a few cells that are sampled. So, as was just mentioned, there's a couple of two main types of PET scans that we use. One is a dodecate PET scan, which is looking at somatostatin receptors, and the other one is an FDG scan, which is looking at glucose uptake or energy utilization by the cell. So typically, again, to use that spectrum example, the lower the K67, the less proliferation there is, tends to be more well-differentiated tumors that do express somatostatin receptors. And so we typically are able to visualize them best with the dodecate PET scan. But as the grade becomes higher, they can lose the somatostatin receptors and become more utilization of the glucose. And so then we can use the FDG uptake to better characterize them. And this does have impact on the treatment decision, because as things are more well differentiated and express somatostatin receptor as well, then we would use things more like PRRT that we discussed before. And as things become more high grade and lose that somatostatin receptor expression, then PRRT is less effective, and we might use other systemic agents or chemotherapies in that case instead. There is sort of this in between group of people who may benefit well from both types of imaging, because parts of their tumors may express somatostatins, other parts may not. That's kind of an evolving area where we're trying to decide, based on the grade or based on characteristics that we see on conventional imaging, such as CT scans and MRI scans, that perhaps we should do FDG scans as well in those patients.
Great. Thank you for that answer. And another question for Dr. Chandrasekharan is that when would you decide I will give chemotherapy versus somatostatin agonist? What will be the clinical characteristics of the patients that make you choose one treatment versus the other?
So the way I try to explain to patients is, what grows fast may respond fast, but that's necessarily not a good thing, right? So, that's just in general, when we talk about these high-grade neuroendocrine carcinoma, or the kind that are very poorly differentiated, we primarily treat with chemotherapy-based as a first-line treatment. Now, within the better behaved or the well-differentiated group, where do we use chemotherapy, especially upfront? Clearly, again, we look at the symptom of the patient, the burden of the tumor, if there's a significant volume of cancer that's already affecting the patient. And we all know that neuroendocrine tumors, specifically of pancreatic origin, are the ones that are more exquisitely sensitive to the chemotherapy type of drugs. And so they may not be the same with small bowel neuroendocrine or other origin tumors. We just don't have a lot of data. But if we get a sense this tumor is growing fast, patient is symptomatic, or there's very high volume, and especially if they're pancreatic origin, that's the person to think about chemotherapy first. Now, Dr. Mittra may also say this is exactly the time we could also, if they have octreotide receptors, on the PET scan, could also be considering PRRT, and we have data from the NETTER too. And not to steal his thunder, but that's a good patient also. But we also have patients who have, for example, in those patients, let's say I'm getting a dual PET, and meaning like I'm getting a gallium PET and an FDG PET. If I'm fortunate enough to have all these data points to make decisions, and I know this patient has tumors that are not uniformly or very strongly octreotide receptor positive, then that would also make me lean towards chemo rather than PRT in that kind of situation. And that's a great question. I'm going to ask a question for Dr. Clarke, if that's okay, Dr. Del Rivero, too. In these grade 3 tumors, the question of surgery comes up too. I'm curious to see how the decision tree is. We always talk about chemo versus PRRT in these patients, but I would also say, hey, what about surgery in these patients?
Yeah, so I would say in general, I do favor a neoadjuvant approach for any tumor that has either a couple of things. If it demonstrates either aggressive biology by location, aggressive biology by Ki67, or aggressive biology by extent of resection that's needed. So what does that mean? For somebody that has perhaps even like a high grade 2, which would be somebody whose Ki67 is in the double digits, that has a very large burden of disease, where I know that the magnitude of the operation, even though technically feasible, is going to be significant. If I'm worried that there's going to be short-term failure in those patients, I do like to give a test of biology, preferentially with chemotherapy, especially if it's a pancreatic neuroendocrine tumor. I just find that operating after PRRT is a little bit more problematic than, operating after systemic therapy in terms of the intraoperative challenges with bleeding and scar tissue, et cetera. So that's my preference. And certainly for grade 3 tumors, my approach is almost never upfront surgery. I think those patients deserve systemic therapy as quickly as possible. We know that their risk of failure long term is dependent on the development of metastatic disease. And so even in localized tumors, I hesitate to do upfront surgery without consideration of systemic treatments first. A few exceptions, obviously, immediately symptomatic, if I'm trying to palliate a particular problem, like an obstruction or perforation, obviously, then we'll manage that. But I think that you explaining to the patients that the risk of failure and their overall survival is really going to be based on the mitigating the risk of developing metastatic disease distantly. And so most of them are in favor, at least for a short-term course of systemic treatment up front.
And Dr. Clarke, I was just wondering for, our audience here, especially for those patients that are newly diagnosed or attending this conference for the first time, how can you define failure?
Well, I think there's a very broad definition. I think there are oncologic definitions of failure of treatment, and I think there are patient-defined failures of treatment. And I think especially for neuroendocrine tumors, where fortunately the majority of our patients present with well-differentiated low-grade disease, their lifespan, even with this diagnosis, can be quite long. And so we do have to measure what the impact of the treatment is to the patient's quality of life against the impact of the treatment on overall survival. So I think a failure from an oncologic standpoint, for me as a surgeon, the thing that I worry the most about is doing a very big complex operation and then having that patient recur, like on the first post-op scan. That basically makes me think that I made the wrong recommendation. I made the wrong decision to proceed to the operating room with a person that had, very aggressive disease and would have benefited from some upfront systemic therapy first. I think another failure is quality of life outcome that wasn't disclosed and extensively discussed with the patient from a surgical standpoint before surgery, so that they're unhappy with the outcomes after surgery. And we can't ever predict everything, but we can predict the most common things. And that they weren't able to sort of talk about how their post-operative state was going to, impact their day-to-day activities and the quality of life. So I think, failure is widely variable, as is success. I mean, I try to make sure that my definition of the end goal is consistent with what the patient's definition of the end goal is. And then we try to match the therapeutic options to that goal as best as possible.
Thank you so much for clarifying that, Dr. Clarke, because sometimes for patients, when they see that terminology, that may be, it can be sometimes scary. So I think the importance of kind of like this, kind of like explaining exactly what that means in the context, as you very nicely described from the oncological perspective. I think it's important to make that clarification.
I appreciate that too. And I just want to make one comment because it really did bring something to mind that you said. Absolutely right. A lot of times too, we're not really clear about what we are looking for. So for some patients, for example, I'm not even necessarily looking for tumor shrinkage. Before I get to the operating room, I would just be very satisfied with no new lesions popping up. And so, they'll have one lesion that's a 2 millimeters larger on a repeat CT scan after a systemic treatment, and they're really worried about that and thinking of that as failure. And I'm like, there are no new lesions. I didn't need the shrinkage, especially not in that location. And this 2 millimeters of growth is really inconsequential. And we're going to proceed, as well. And then also, they may think like lanreotide or something else is failing because they don't see shrinkage. And we know that that's not the case. Again, we're really just trying to make sure that we have all the lesions identified as much as possible so that we know what we need to take out at the time of surgery. So I think you're right. The definition of failure means something different to the patients as it does to us. And so I think the due diligence is on us to try to explain what exactly we're testing, what are we looking for, what do we expect to happen, and what's consequential and what's not.
And just to add to that, I think that's true across the spectrum of all treatments, not just surgery. I think, PRRT especially, I feel like patients, when especially now it's already a decade old, so some patients know a little bit more about it. But when it came about, it was like this magical, Erik, it is magical, sorry. But in terms of, the expectation that people have from it, like, oh gosh, this is just going to melt away my tumors or something. I mean, if you really show them or share the data that's there, our goal is, even with PRT or even some of the other drugs, is not that these tumors, all of them always do shrink. Again, it's just a different tumor, right? So we have to explain. I tell them the success of the PRT is not measured sometimes during PRT. If you tolerate the treatment without complications, that's a success, right? That's number one. But not having side effects immediately, that's a success to me. The success from a treatment perspective and the efficacy is, especially for something like PRT or even other drugs, is about stability longer term, like how long least quality of life impact you can be with least bothersome symptoms from the tumor you can be. And I think it seems like, especially with the PRT, it seems like this misconception maybe that, again, we do see some amazing responses in those high-grade tumors, but that's not the goal. I think people, our goal, it's happy to see it. I'm sure people love to see those scans look better, but, we want a goal that's far-reaching beyond that.
Yeah, I agree. I agree with everything you're saying here. And sometimes we see a patient and then they may come to you for a second opinion, right? We always say, well, if you see two different experts, you may have 5 different opinions. And kind of like the question is like, when do you think is the right treatment option?
This is also a hard one because there is no right treatment decision, right? All are correct treatment decisions is the first thing we start out with. And that's why I think this is sometimes very confusing for patients, sometimes confusing for the people taking care of this cancer, right? Because we all have these tumor boards where ideally, if you have a medical oncologist, surgeon, and interventional radiology and nuclear medicine folks, all four of us saying, yeah, we can do this. We can offer what we can offer, right? I can offer drugs. Dr. Mittra can offer PRRT. Dr. Clarke can be able to offer surgery, especially for some patients who are super healthy and are a candidate for everything. I mean, the good news is it's all up for offer. That's what I tell people. Hey, again, try to talk to patients in a way that if you go down this path and if it goes well, it looks like this. If it doesn't go well, it looks like this. And so kind of walk down each of these paths and then try to come up with a framework of decision that is helpful for the patient in the context of their lives. Again, a discussion, let's say, for a young patient with radioactivity may be different from a patient who's a little bit older, or a young person, we may have a bias for surgery because they're going to hopefully spring back and do this thing. So I think that part is where maybe the nuances of discussion may vary from one center to another or one patient to another. But the answer we have to emphasize for the patient is all are correct answers. And that's true because we still don't know the right answers to sequence.
Dr. Mittra?
Great discussion, and I really agree with a lot of what has been said so far. From my point of view, I would just stress a couple of things that, again, I feel like have already been said. But one is that it's really important, as was just mentioned, to understand that even we don't really understand what is the proper sequence of these things. So there is really no wrong answer to that end. It's important, as was mentioned, to just really kind of understand what each of these therapies entail. And then, as Dr. Clarke said, to really understand, what it is that your goals are out of this, treatment. because perhaps, surgery is something that is potentially very good for you. But if you don't want to go through that and, have the recovery from that, as an example, PRRT is very, very well tolerated. It's given once every 2 months. It's very easy to do. It has to be kind of a combination of all those things. And again, I mentioned before that, we discuss all of these things in the multidisciplinary tumor board. And I do think that's important, especially since we don't have clear understanding of the sequencing of some of these therapies. If we can get sort of a consensus of, multiple experts, so to speak, agreeing on this thing, then I think that's also helpful.
I would say I think the right patient, the right treatment's probably determined by the patient. I think that, having comfort in the treatment plan is really critical. I think that if you feel like either you don't understand the reasons behind the recommendations or the recommendation hasn't really addressed your major concerns, that may not be the right treatment plan for you. And I really encourage folks to get a second opinion in those settings if they're not entirely comfortable with the treatment plan, because they will get different opinions at different centers. And that could be, from my standpoint, especially, like I will see a lot of patients with what I consider low risk, small, non-functional, incidental pancreatic neuroendocrine tumors. We at our center really favor observation for the vast majority of these patients, with some exceptions. But there's some patients that just don't feel comfortable watching a small tumor that's a centimeter in size, and even with the data presented, they may want to pursue surgical intervention somewhere else, and there's nothing wrong with that. I actually encourage that sort of debate and discussion. And again, the patient has to be comfortable with the plan, just as much as I think the treating team have to be comfortable with the plan. I think it's really a matter of trying to get the outcomes really aligned with patient wishes as much as possible.
Thank you. And I would like to ask a question to the three of you. What advice would you give to a patient who is newly diagnosed with neuroendocrine tumors in terms of treatment decisions or treatment recommendations?
I think knowledge is power. So is in every cancer, but this is a long journey, hopefully a very long journey for most of a patient. So there is nothing wrong in equipping yourself with the knowledge first. There are also patients who may opt not to, and that's fine too. I just want to make sure there's no right way, I'm sure, from a patient perspective. But some will say, just don't tell me about this, doc. Just tell me what to do. That's fine too. But if you're the kind that likes to know and be involved, that's absolutely necessary in this cancer, because the more you know, you are still going to be the centerpiece of all these decisions. You're the one going through the treatments if you need them. You're the one with the toxicity. So you have to express yourself and ask all these questions. So equip yourself with knowledge, speak up. It's okay to seek an opinion, like Dr. Clarke mentioned, seek an opinion. If you're, it's okay to do that. Again, there's nothing wrong. And make sure you're comfortable with your team.
Yeah, Dr. Clarke?
I actually refer patients a lot to the Neuroendocrine Cancer Foundation and to any patient-centered groups. We have a very active patient net group in Wisconsin. And so I recommend that they get to be a part of the net patient community, because a lot of what I say sounds like a reasonable thing, but there's nothing, I think, more powerful for a patient who's sitting in a chair, who's very scared and devastated by this new cancer diagnosis, like talking to somebody who's sort of been through what they're going through. And so talking to other patients who sort of navigated or are still navigating their neuroendocrine tumor journey is probably like one of the most beneficial things that I think a net patient can do. I also tell them to forget about everything they've heard about cancer, because almost none of it applies to their particular tumor, and everybody's going to tell them what they think. And it's not going to be relevant, because this is just a totally different beast than the typical cancers that they're going to encounter amongst family and friends. So I agree with Chandrikha. I think knowledge is power, and a lot of that knowledge can actually be gleaned from folks who've been through this diagnosis or still navigating that diagnosis. And I think it can help them understand their disease and disease course and potential for long-term outcomes better than anything that we can explain. I think it can familiarize themselves with other experts in neuroendocrine treatment across the country that they may not be privy to just in their regional circles. And then I think it's particularly helpful for caregivers to really get a better understanding about what next steps or what the next years will look like for their loved ones. So I really encourage patient-centered support groups as much as possible.
Thank you for that. And Dr. Mitra.
Not much to add to those. I completely agree with everything that was said so far. Those are great things to do. The only thing I could think to add would be that a lot of times, since this is a relatively rare, uncommon disease, that in physicians in the community often don't have a lot of experience with it, and this is again a very nuanced type of management, as was just mentioned. So, if it's possible to go to a center of excellence, or at least a center that sees more neuroendocrine patients at some point, it would be probably advantageous for you to just be connected to them. You can still kind of be connected to your local oncologist and local physicians for sort of your day-to-day care, but I think it's good to also see some specialists if possible.
That's the very, very important information. Knowledge is power, and going to support groups and get you informed about the symptoms and like what is the workup. And that way, patients can make the treatment decisions. And like you say earlier, Dr. Chandrikha, I think the voice and Dr. Carr also say is what the patient decides, as long as we understand all the risk and benefits and what makes sense in terms of the clinical presentation of the patients. I think is also important. And earlier, all of you mentioned about like the importance of multidisciplinary teams, multidisciplinary care, and in patients with neuroendocrine tumors. And we know that a lot of us, or most of us here, we are in institutions that we have the multidisciplinary team needed to treat those patients, but we also have patients that may not necessarily have that. So in those situations, what would be your recommendation in a patient that may not have access to the academic centers that they have all the different specialties? So what would you recommend?
So I think all of us do practice in an academic center. So, right, I think we do have that luxury of having the team, the colleague that you can call from radiology, nuclear medicine, surgeon anytime. So I have great respect for the people taking care of the patients in the community. And the access comes twofold, right? The access is a patient not being able to get to a specialty center, but there are various factors. But in terms of accessibility, I would say, for example, a doctor who's treating this cancer in the community has a patient who's not able to get to the center. They still have access to other resources to reach out if they only see one or two patients in a year with this cancer. In other words, there are ways to mitigate it. It's a very tall order. Having video visits and virtual visits, like a lot of us have started to do that. Thankfully, having those liberal state licensing things and have enabled some patients with access issues still be in touch if possible. So I think we have to get creative, both as a physician treating team as well as the patient group and advocacy to address this, to offer what we have to offer for more people.
Thank you so much for that question. And we are coming at the end of our session. But if you mind asking, then maybe we can start with Dr. Clarke. What is the single development that you're more excited right now about neuroendocrine tumors?
Wow, I mean, that's a tough question. I just think that really it's the trend. It's an explosion of new therapeutics that are specifically focused on this disease. I think, we've been an orphan cancer for so long. We are just now starting to reap the benefits of decades of investment and innovation, research, and inquiry in neuroendocrine tumors. And so we're starting to see a lot of new, more personalized options for tumor treatments and more precise treatment options that offer perhaps the benefit of enhanced tolerability and even maybe wider access outside of some of these, centers of excellence. So I think that has been the thing that's most exciting. And I tell people now, like, sometimes in many cases, not in all cases, but certainly even with somebody that has high volume grade 1 disease, that, we're going to try to play whack-a-mole with your disease for as long as we can. We have a lot more tools in our box, and we're going to try to use the right one at the right time to manage your disease, minimize the side effects of the treatment, and then try to keep you alive as long as possible. And we can actually say that now with a reasonable amount of confidence, whereas I don't think we were able to say that 20 years ago.
Dr. Mitra?
I mean, that was perfect answer from Dr. Clarke, so I really can't add much. The only thing I would say is this is going to continue. Over the last 10, 20 years, we have had so many developments, but even more so coming in, the next 10 to 20 years. So it's a lot of exciting things to look forward.
I'm actually excited about the investment and the interest in this cancer to begin with. I think that's kind of where it starts. I think there's a concerted effort, hopefully from multiple levels to, again, rare orphan, yes, but I think all this progress has been possible because there is still the commitment to make progress, right? So that's, I think, key, and that momentum, I think, will continue. And so that's important. And then two, probably is, the excitement is also about some new models we can study these tumors. As technology in other places are increasing, we're going to have to immediately start applying it in neuroendocrine tumors so we can do better.
Well, thank you so much. Thank you everyone for being here today. And this concludes our session, and get back to you.